So what investigations do we have when the patient not only comes to our clinic, but is subsequently admitted to hospital? Well, first line investigation that I tell all my trainees is this must really be completed in all patients. And unfortunately, despite lecturing in Ulster University on a regular basis over the last 10 years, I do still see referrals from the community, particularly from our podiatry colleagues who have been referred without any measurement of angiobrachial indices. I do, however, appreciate that a lot of patients in the community are diabetic, but in the hospital environment it does give me a clue. For example, if I see a very low angiobrachial index when I see the referral letter, that will aid urgency for clinical review. If I see a very low angiobrachial index, it does allow me to fast track, and I may also arrange cross-sectional imaging before I even see the patient in the clinic if they've got tissue loss. So angiobrachial indices performed in the community is very helpful to us in the hospital setting, and in my practice I believe it fast tracks their treatment. To revise, angiobrachial indices are calculated in both dorsalis pedis and posterior tibial pulses. A cuff is applied just above the malleolar region, and the cuff is gradually inflated to a point where the signal on the Doppler dissipates, and then it's elevated a further 10 to 20 millimeters of mercury and then gradually deflated at slow increments. Restoration of flow is the systolic ankle pressure. This is then performed for both pulses in both feet, and we also compare that with a brachial pressure. It's also important that when you perform Doppler assessments that you listen for the quality of the Doppler signal, whether this is monophasic suggesting severe disease or whether there's a nice biphasic or triphasic signal suggesting no major arterial issue. Angiobrachial indices less than 0.9 do generally indicate an element of peripheral arterial disease. However, in the absence of any symptoms and in the absence of any tissue loss or any other concerning factor, I do not need to see a patient who just has a low angiobrachial indices. If you report back to the patient's GP and say this patient has reduced angiobrachial indices suggestive of arterial disease, this then gets translated to please see podiatrist letter and review in your vascular clinic. You then bring the patient up who says I can walk 2 miles with an ABI of 0.75, I will not be intervening in this patient. And what that effectively does is this reduces my ability to create slots for urgent patients who may have an angiobrachial indices of maybe 0.6 but who have gross ulceration in their foot and warrant immediate or urgent investigation and treatment. It is important to realise that false elevation in angiobrachial indices do occur, and figures greater than 1.3 can occur in patients with diabetic calcification or renal failure, but it's also important that this can be a normal phenomenon in younger patients, athletes, patients with hypotension as well with a low brachial pressure at outset. Angiobrachial indices has been shown to be a predictor of mortality, and what that basically means is that if you have a very low angiobrachial indices, it's really a surrogate marker for global cardiovascular disease. We used to do a lot of segmental waveforms, and essentially what these were angiobrachial pressure measurements throughout the lower extremity to give us a reading. During these segmental waveforms, we also identified whether the pulse was biphasic or monophasic, and I personally found these quite useful, but they are relatively time consuming, and I believe arterial duplexes probably have more benefit as this can delineate the actual area or location of the stenotic or occluded segment. Exercise ABI for me confirms the diagnosis, and I would imagine in my practice approximately 5 to 10 patients per year have normal resting angiobrachial indices, but they have excellent histories completely consistent with claudication. They generally tend to be younger, they're wanting to be fitter patients, they expect more from their quality of life. You then put them on a treadmill, walk them as far as they can go on the treadmill at various elevations, and once they have reached maximal capacity in the treadmill, check their angiobrachial pressure indices, and often you see a significant drop. In these patients, they often have a lesion that we can intervene on. So it's very good at unmasking peripheral arterial disease, and I do believe it's underutilised. Arterial duplex has a big role in my practice. I see a lot of diabetic patients. I see a lot of patients with renal impairment, And in these patients, cross-sectional imaging with contrast agents does precipitate further renal issues, and therefore with a dedicated arterial duplex giving me the information that I want, I actually, if they have a palpable pulse, can proceed straight to endovascular intervention without the use of cross-sectional imaging. My other rationale for this is that infrageniculate vessel evaluation with cross-sectional imaging is often disappointing, particularly when there's calcification within the vessels or when there's significant disease to the proximal segments, therefore reducing flow through that vessel. Arterial duplex is very useful for any planned intervention, both endovascular or surgical. Can select the site of surgical anastomosis, which has helped me sometimes whenever I've not had as long a venous conduit as I wished for a distal infrageniculate bypass, and it's also useful for following up certain patients after intervention. Magnetic resonance angiography is really depending on the unit preference. If you receive nearly 2,000 images from the scan, it is very difficult as a non-radiologist to identify where the lesion is. However, if you are in a unit where you get excellent reconstructed imaging, you can get fantastic pictures. This is actually a 32-year-old patient who presented with bilateral popliteal occlusions, and we initially published this as he was a competitive BMX bike rider, and we thought that repeated flexion and extension of his knee caused fibrosis and subsequent occlusion of his popliteal arteries. However, over the next 5 to 10 years, ultimately, despite our best efforts with endovascular intervention and bypass, this patient eventually lost their lower extremities, and given that he was a smoker, we felt that this was most likely Berger's type atherosclerosis obliterans picture. CT angiography is also excellent. It does, however, carry a radiation risk as well as contrast. So both magnetic resonance and CT imaging do have renal related risks due to contrast agent, where gadolinium in magnetic resonance angiography can lead to nephrogenic systemic fibrosis, which can create long-term problems for the kidney, whereas contrast used in computerized tomography angiography is often short limiting and if required can be dialyzed off in the hope that renal function is restored. My main issue with CT angiograms is the below knee segment in diabetic patients. We often see that there's a lot of calcification. The vessels are very small, flow is limiting, and for me, on a very frequent basis, I'm not entirely sure if there is flow in those vessels, and therefore arterial duplex can help me delineate a bypass location for distal anastomosis, or conventional angiography may be appropriate as well. Here we can see excellent pictures both of the aortoiliac segment and also reconstructed images of the infrageniculate segments showing excellent triphasic vessels. The transfemoral angiography route, it's invasive, and for me this is not only for diagnostic purposes but more for a look-see with potential treatment. Here we can perform angiography with a small amount of local anaesthetic in the groin area. We then pass a 19 gauge needle followed by passage of endovascular wire and then exchange of the needle for a sheath to facilitate our angiogram. Depending on what we find, we can then intervene both going upstream towards the aortoiliac segment or downstream towards the superficial femoral and distal vessels. In this slide we can see a superficial femoral artery occlusion at the ductor hiatus that was successfully crossed with a V1 8 wire and then balloon angioplasty. I tend to avoid the use of any stents in the superficial femoral artery unless I have to, and drug-eluting technology is evolving in this process with better patency rates. So if we go back to global clinical evaluation, it's all about blood supply and septic load. When we look at septic load evaluation, to me, diabetic foot disease can be horrific. This is a slide that was published in the Daily Express from the New England Journal of Medicine, and this really shows what can happen over a 10-day period with a diabetic foot abscess. My overriding concern is, why was this patient not treated? rather than having pictures taken on a daily basis of their leg becoming ischemic with increased sepsis, ultimately leading to limb loss. So if we look at this lower extremity, I'm just going to pause for a few seconds just to allow you to inspect and figure out a number of positive findings in this lower extremity on inspection. We can acknowledge that there are different shades on all the nails, but it's clearly obvious the right fifth toe has a problem and it looks ischemic in origin. If we track this slightly more proximally, we can see that there's a small point which is purple in nature, and this could be the pointing abscess in the dorsal aspect of the foot. A number of other issues for potential sepsis is that there's skin marking, and it looks as if the redness has regressed, suggesting that there possibly is a response to antibiotic treatment. For me, from an arterial perfusion issue, the toes themselves do not look overly pale. The foot itself looks relatively well perfused, and I can see hair in the right first, second and third toes, suggesting that there may not be an arterial malperfusion issue. Doppler assessment at bedside and palpation of pulses is important in this case. So when we look at clinical examination, we really want to follow the International Working Group on Diabetic Foot from Lipsky's leadership, which he is a doyen of diabetic foot disease worldwide. They look at the PEDIS classification, which essentially is perfusion, the extent and size of the infected area, the depth and element of tissue loss, the degree of infection, and also whether or not their sensation is preserved or absent. So grade 1 wounds are really uninfected, they're just a break in the skin. Grade 2 wounds have mild infection, potentially the skin or maybe even the subcutaneous tissue, and are usually small in diameter. Grade 3 lesions clearly are getting a bit bigger, affecting the skin, subcutaneous tissue, and perhaps even deeper the bone, joint or tendon. And grade 4 infection is where you have a severely infected wound with systemic upset. So how do these gradings affect us? How do they lead our diagnosis and treatment? Well, this sort of gauges for you in the community or you in the outpatient environment whether or not you need to instigate oral antibiotics or whether they need to be stepped up to intravenous and admission to hospital for more intensive management. So one of my biggest issues, and I learnt this in the Mayo Clinic when I was a fellow a number of years ago, is the use of tissue swabs, tissue sampling, wound swabs versus actual proper culture of material. And to digress, I sent a wound swab in my first few months from the outpatient clinic. The patient was very sore, wouldn't really let me probe the wound, so I just popped it in through the sinus and sent that off. This breached protocol so much so in the Mayo Clinic that actually the microbiologist came to the operating department, dressed into theatre scrubs, to personally come into my OR room to berate me for sending a wound swab. He advised that tissue or some other sampling of core specimen was essential and that wound swabs would not be tolerated. And I can appreciate this because wound swabs either are non-sensitive or just demonstrate the biofilm and maybe not the infective organism. However, let's look at some of the most recent research. Well, let's look at tissue versus swab culturing of infective diabetic foot wounds. Well, it suggested in this article by Huang in 2016 that for more minor wounds, grade 2 on the PEDIS classification, that just a swab may be reliable. However, I'm not going to personally stand by that because I still believe we need to send tissue. They're quite clear in this paper that any wound of grade 3 and grade 4 does need to have some tissue. And this can be just scrapings of the deep tissue just to get a better sample. And here we can see just sampling spigot to try and take some of the actual wound ulcer tissue, and that's sent off to the lab. Always try and send tissue whenever possible. So what about bone biopsy, and more so percutaneous bone biopsy specimens? Well, Seneville looked in 2006, which is over 10 years ago. They looked at 76 patients where they had 81 episodes of osteomyelitis in the foot area. And what they did is they looked at surgical percutaneous bone biopsy specimens from a single foot clinic, which gives you a fairly defined patient population. They were antibiotic naive for 4 weeks, and specimens isolated from the bone samples were predominantly staph and gram-negative bacilli. They did look at the distribution of microorganisms between the bone and swab cultures, and they were similar, but coagulase-negative staphylococci were more prevalent in bone samples. So if you do not send a proper sample or a bone sample in this paper, you may miss the coag-negative staph, which are difficult to culture anyway. The one thing just to identify is that their bone and swab cultures were only identical in just over 17% of patients, and a concordance was less than 50% for all specimens, but even less than 30% for gram-negative and streptococci. So when they looked at that, they also comment whether there was any adverse events. And in my practice, I do worry in vascular patients about doing a bone biopsy, creating a fresh wound in an already problematic foot. But they didn't identify any issues with deterioration of peripheral arterial disease, fracture, or biopsy-induced bone infection. But they did have one acute Charcot issue 4 weeks after bone biopsy. I'm not entirely sure that's related to the bone biopsy. So they concluded that superficial swab cultures do not reliably identify bone bacteria. However, percutaneous bone biopsy does appear to be safe for patients and does identify appropriate organisms in diabetic foot osteomyelitis. So when we look for a more review paper, and with L.M. Murrigan looked at bone biopsy specimen in diabetic foot osteomyelitis, they looked prospectively at consecutive patients, and there were over 100, so it's a larger study from 2011. They looked at superficial swab and percutaneous bone biopsy, and they identified positive samples in nearly all patients, and the mean number of isolate was similar in both cultures, but the bone pathogen was identified only in 38.2% of cases, which is very interesting. And Staph aureus again has the highest concordance. So really, either mechanism is going to identify Staph aureus is what I feel. It's all the other bugs that we need to treat, and it's those bugs that if you just have a patient on flucloxacillin for their Staphylococcus aureus, that's probably why you're not getting any resolution of the cellulitis. So these authors concluded that a superficial swab culture may not be accurate in identifying all the organisms, and that simultaneous bone biopsy does increase the accuracy of bacterial isolates. So we look at some of their data. This is just a range of infective agents that they identified, and this is standard for most diabetic foot practices. However, their concordance between the ulcer swab and bone biopsy, both in patients with suspected osteomyelitis and those with radiological osteomyelitis, was very low at less than 15% for both these groups. So what are my concerns? Well, I think successful antibiotic treatment is more likely to occur when the choice of antibiotics is guided by cultures. That's a no-brainer. That is really easy to keep in your practice. However, if surgery is not performed, I do worry about bone cultures being performed via the percutaneous route. I worry that in potentially healthy bone, you introduce patient discomfort if they're not neuropathic, and also you're potentially affecting stable bone that could become infected. So regardless of the previous evidence that I've reported, I do still worry about that. However, I do believe in operative sampling. To not send a bone sample, I don't feel is in any way appropriate, and bone samples must always be sent from the operating room. It's quite interesting to know that 1 in 4 normal results of transcutaneous biopsies were false negatives. And they also commented that needle aspiration has a small concordance with transcutaneous biopsy results. So really, that's not needle aspiration of bone or tissue is not really of much help. And the needle aspiration for me is more, is there fluid that's infected there? And if there is, I'll aspirate it with the needle and then lance and open up the area under local anaesthetic, or without if their patient's neuropathic. So recommendations is that bone is best sampled under direct vision or reasonably sized percutaneous biopsy, which I'm still hesitant in my own practice, but it is acceptable in some units, but I don't think we're currently at the stage of performing this on a regular basis in Northern Ireland. I worry about tissue breach. I worry about a remote biopsy wound that can be infected or inoculated via the infected wound, particularly if it's a very resistant organism. I worry about patient compliance, and I also worry about healing in someone who's got poor arterial perfusion. I'm not going to dwell on antibiotics, as I believe this will be covered elsewhere in your module. However, my own foibles is that you need to adhere to hospital trust protocols. You cannot be a maverick and just start whatever you want. However, first line for me is really a tazocin for all patients, as I believe this covers a lot of gram positive as well as some gram negative and anaerobic cover. I do continually remain aghast at single agent therapy in chronic diabetic foot wounds that are simply not progressing clinically. And what I mean by this is that a lot of patients are placed on flucloxacillin as a solitary agent. The wound is left for potentially 3 to 7 days without any improvement, and nobody feels the need to amend or adjust antibiotics. So regular patient review, particularly for their wounds on a regular basis, is vital. And it's important that if you're taking a microbiology sample, please look up the sensitivities and optimize antibiotic therapy as required.